All right, so this week we're going to talk about the shoulder, our last topic in preparation for your midterm. Mainly today, I just want to talk to you guys about the anatomy, mainly of the shoulder girdle. We've talked a lot about the proximal humerus when we did humerus. We'll talk even more about the scapula when we get to the scapula views, and a little bit of the clavicle as well, which also has its own views. So anything that you're not quite grasping from scapula, from clavicle, we will be kind of reinforcing that later. So starting with the clavicle, even though it is considered, or is pretty small, it is considered a long bone. You'll see that it has one flat end here and one more kind of rounded end. The rounded end is the sternal end. That's where it articulates with the sternum to form the SC joint, or the sternoclavicular joint. And the flatter end is the acromial end, and that's the end that articulates with the acromion process on the scapula to form the acromioclavicular joint, or the AC joint. So this is a really common joint to injure during sports. If you've ever heard somebody say they've separated their shoulder, it's where the clavicle here at the acromial end articulates with the acromion process to make that AC joint. The scapula is much more confusing, I would say. It has a lot of different pieces and parts. So looking at the scapula, we're looking at the anterior aspect of the scapula here. We can see that there's a lateral border, a medial border, and a superior border. There is no inferior border because it forms a point. So instead we have angles. So we have an inferior angle here, but we also have a superior angle on the other side. When you're orienting yourself on an image, trying to decide what side's lateral border, what side's medial border, it'll make a lot more sense because you'll be able to see where the patient's spine is, where their humerus is, and you can kind of identify it that way. But if you're looking at just a picture of the scapula and trying to identify what side's what, which side's medial, which side's lateral, always look for the glenoid process here, where the humeral head will articulate to form the glenohumeral joint. Since that's where the humerus will articulate, that side's always going to be the lateral side. So lateral border goes right up to the glenoid cavity, or glenoid fossa, where it'll articulate with that humeral head. There's a couple of important processes on the scapula as well. The one that points anteriorly is the coracoid process. That'll be an important point of reference when we do scapula views, and the acromion process, which is something that you can palpate pretty easily, which will be important when we do clavicle and AC joint views. You'll also notice that we can see a fossa here on the anterior side. It's called the subscapular fossa. Sub means below or before, so this is referring to the fossa that's before the scapula. It's the anterior side. It's also where the subscapularis muscle sits, so part of your rotator cuff. On the other side of the scapula, we have a little bit more as far as anatomy is concerned. A couple of more fossae for some more rotator cuff muscles, as well as a spine of the scapula, which you've already used as a marker to try to find where that T3 is when we're doing our posterior axial apical views of the chest. So the spine is continuous with where the acromion is, so this is, you can see a piece of that spine of the scapula back there. And here's an image that shows that. We can see spine of the scapula continuing on to become acromion here at the more distal end. And it separates the two fossae that are posterior. The supraspinous fossa, supra meaning above, so above the spine, and infraspinous fossa, infra meaning below, so below the spine of the scapula. Remember, a fossa is just a depression, so it just means that there is kind of a lowering in elevation in the surface of these parts of the bone. The muscles that sit in these areas are also named after the fossae. So the supraspinous fossa holds the supraspinatus muscle, infraspinous fossa holds the infraspinatus muscle, also teres minor that kind of tags along. So we've talked about all of the articulations. The humerus itself is not considered to be part of the shoulder girdle. When we're talking about the shoulder girdle, also known as the pectoral girdle, we're referring to kind of those accessory bones that are helping to form those shoulder joints, and the joints around the shoulder that aren't considered true shoulder joints, like the AC joint and the SC joint. So scapula, clavicle, and just those areas there. Much earlier on, we've talked about different types of joint classifications. The shoulder is considered diarthrodial. It's a ball and socket type joint. It's a synovial joint. So just like all of our major joints in our extremities, this is a synovial joint, meaning it has a ton of range of motion in comparison to more cartilaginous or fibrous joints. And ball and socket has the most range of motion of those types of joints. That means that despite it having all of these ranges of motion, it also makes the joint a little inherently unstable. So because it can move in a bunch of different directions, it's easier to injure that joint. It's easier for it to dislocate, things like that. So we've talked a lot about how to do the setups for the actual shoulder. I'll kind of reinforce that a little bit, remembering that we need to remove any bra straps since they will likely have metal on them. Any jewelry around the area, especially necklaces. If there's any buttons on clothing that are metallic or zippers, to remove those as well and just have the patient change into a gown. Remember that any of the procedures that we're doing for this week can be performed upright or supine. But most of the time you'll be performing them upright unless the patient comes in on a backboard or is in such a traumatic state that they can't really stand. Remember also that you can keep the IR either horizontal or vertical depending on what we're looking for. So if we consider there to be a higher risk for more clavicular type fractures or dislocations, if we're worried about the SC joint, if we're worried about the AC joint, then we'll make sure that we get this horizontal view so that we can see a little bit more of that clavicle versus a vertical IR, which will be important for looking at just the shoulder joint and catching a little bit more proximal humerus. Most of our collimation is going to be 10 by 12, and if you were to use the cassette sizes down in the practice lab, you would use a 10 by 12 cassette instead of 14 by 17. SID is the same as we've seen so far for extremities, 40 inches or 102 centimeters, and then we're just going to mark the side of the shoulder that we're doing. So right shoulder gets right marker, left shoulder gets left marker. We could use gonadal shielding. It's not necessary, but depending on your facility that you work at, they might reinforce using that gonadal shielding, using the opposite arm to hold up the shield over breast tissue. Remember, just like humerus, we're going to have the patient hold their breath. It doesn't matter if it's on inspiration or expiration, just holding the breath in general, so that while they're taking the image of the shoulder, it's not going to be moving at all with the movement of the chest. Okay. Remember, for internal rotation, we're going to take the thumb and rotate it all the way inwards. It's going to be pointing almost behind you, depending on the degree of internal rotation. If the patient can hold it like that, if they don't have a lot of internal rotation, remember they can rest their hand on their stomach, on their hip, or behind their back for patient comfort. It can be performed supine or standing, and oftentimes we'll be doing that standing. You'll see that the central ray says that it enters the patient an inch inferior to the coracoid process, but a really easy way to get there is by finding the joint line and kind of bisecting the middle of the joint line. So finding the axilla, finding the top of the shoulder, and going right in between, you get kind of in that same area. For coracoid process, it's a little bit of a tricky palpation since it is a deeper structure and it is a little tender to touch. But you would essentially reach over the patient's shoulder and kind of dig your finger into that anterior soft tissue there, right near the clavicle, and you should be able to find that coracoid process by the way that the patient jumps. For internal rotation, this is where we're going to see most of our lesser tubercle of the humerus. So remember, on the proximal humerus, we have our greater tubercle, our lesser tubercle, and that intertubercular groove that goes in between, also known as the bicipital groove, since that's where the biceps tendon sits. Since we're internally rotating, we're going to be able to see a nice, good contour of that lesser tubercle, since it is the more medial structure. But now we can't see that greater tubercle as well, since we've internally rotated, and now we're kind of seeing it on profile. External rotation, we can also do standing or supine. This time we're rotating our thumb outwards so that it's almost facing behind you, but the opposite way. Again, arm will be abducted, but only slightly, not quite so much as you would for the humerus. Everything else is the same. You're going to put central ray in the same place. You're going to put the collimation the same, that 10 by 12 box. And on external rotation, we can see the greater tubercle much better. So notice when I'm showing you to put the central ray kind of where that joint line is, we're palpating for like right about here. Versus if you go based off the coracoid process, we're going right about here because it's an inch below. So it's up to you which one you want to use. I think it's a little trickier to try to find that coracoid process, or if you wanted to find joint line and move a little bit more medial to the patient, that's also okay. We're still going to catch all of these structures. For neutral, this is again a traumatic position, just like we would do for the humerus. So patient probably doesn't want to move their humerus too much to do this projection. So instead, thumb will be facing outward toward the radiographer. Collimation's the same, SID's the same. And this time we don't really get a good view of really the greater or lesser tubercle, but we can see a little bit of the greater there. In Grashi's view, is best for looking at the joint line. So it'll depend on the facility you go to, whether you have them internally rotate, externally rotate, but for the purposes of comps, we'll do internal rotation. And remember that it's really easy to rotate the patient too much, so we're going to want to make sure scapula is nice and flat against the buccal, and that angle of 35 to 45 degrees is going to be based off of how much that shoulder joint itself is rotating off of the buccal, not the patient themselves. We've also talked about in lab what RPO and LPO stands for. Remember, RPO is right posterior oblique, LPO is left posterior oblique, so that's just telling you what shoulder and what part of what shoulder is contacting the buccal. So if we did a right posterior oblique, then we're imaging the right shoulder for a Grashi's position. But if we did a right anterior oblique, we'd be imaging the right shoulder for a scapular Y view. So keep that in mind for test questions. So it's just giving another view of how far the patient should be rotated. And we can see a nice clear view of that joint line. And all the other views that we've seen thus far for the greater tubercle, for the lesser tubercle, and both external rotation and internal rotation and even neutral, the humeral head was overlapping with the glenoid, but now we can see a nice radiolucent line to see right through the joint line. Another view that we can do for trauma is the transthoracic lateral, which can either be supine or standing. The one I showed in lab is standing, where the affected limb is closest to the buccal, and the unaffected limb is the one that's raised over the head. So we're actually shooting through the chest to image that opposite shoulder. So we aim about 2 inches below the axilla, and we try to get that vertical line in line with the humerus that's being raised over the head. Really important on this one is to set the collimation before the patient steps in front to that 10 by 12 box. Don't touch it after you come back to the machine, and to ensure that the patient's not rotated, because a lot of this positioning is relying on the fact that the shoulders are at an even level, but that opposite shoulder, the one that we're imaging, is dipped down a little further. But if the patient's rotated at all, that central ray won't actually be going through the humerus. It'll be going through soft tissue or maybe off to the side into just straight air, and maybe we'll get a chest projection instead. So it's important to try to line them up completely neutral if possible, with no rotation. Everything else will be the same. Same kind of thing for holding respiration. And we certainly don't want to collimate larger than the stated size to get something more like a lateral chest radiograph. It does say that you can angle 10 to 15 degrees cephalad in order to get a better view of the shoulder. If when they raise this unaffected arm, it's on the same plane as the affected arm still. Don't worry about that for comp's sake, but just know that that's something that you could do if you don't feel like you're going to actually capture that shoulder with putting this central ray so low. And if I were to give you an image like this on your test, you would know that this is a transthoracic lateral because we can see that humerus, but with tons of superimposed ribs. We can see the thoracic spine. So all these superimposed structures that wouldn't actually be there on any other shoulder projection. The infrasuperior axial projection is also a Lawrence method. This is done supine. The head and shoulder are elevated with usually like a foam board or pillow, about 3 inches. And they turn their head away from the IR. The arm will be abducted to 90 degrees. And if they can tolerate it, they'll put it in external rotation, rotating their thumb outward. The IR is placed crosswise on the table, and we center the central ray to the joint itself, so right kind of mid-axilla. We'll have a little bit of a tube tilt of 15 to 30 degrees. We'll have a great view of the AC joint, the glenohumeral joint. And this is what that would look like. So we can see the glenoid, but from the inferior aspect to form the glenohumeral joint, which is often called the scapulohumeral joint. But the part of the scapula that's articulating with the humerus is the glenoid, so that's what its more common name is, glenohumeral joint. This is a really good view for looking for dislocations, just like the scapular Y. So that's what they're looking for here. This is a really normal contour of the humerus. But on somebody who's dislocated their humerus, sometimes they get these notch defects out of the humeral head, where the humerus kind of bounced off that glenoid and took a chunk out. So it's called a hatchet deformity. It's not something that you have to know for your test, but in case you were to see something like that, that's a pretty good sign that somebody dislocated recently or in the past. In this case, it's recent because glenoid's all the way over here, and they're not quite articulating with the glenoid as much as the picture above it. And still we can see slight overlap on a normal humerus for the humeral head and the glenoid. We shouldn't be able to see straight through the joint line like we would for a Grasschi's. Scapular Y, this is another oblique, but now it's a posterior oblique. A P to A oblique, which is actually an anterior oblique, I suppose. But this is a good way to look for dislocations as well. And remember, it's called a scapular Y because when we look at the image, the scapula forms a nice Y shape with a superimposed humerus over top. In this case, we have an RAO or an LAO, so it's just talking about what side is closest to the bucky. Right anterior oblique is the right shoulder, left anterior oblique is the left shoulder. So a patient will orient themselves, or you'll orient them 45 to 60 degrees in that anterior oblique position. You'll palpate the scapula and make sure that it's kind of perpendicular to the IR. So we don't want it to be as flat as we would for something like a Grasschi's. We should kind of be shooting through it. For this, remember the arm position. We don't care if it's internally rotated, neutral, externally rotated. What's important is that the patient's comfortable because likely they're coming in with trauma. Central ray should be going perpendicular to the glenohumeral joint. So if the patient's rotated enough, we're kind of shooting through the scapula into the joint line. So they're kind of lined up in that way. So you always want to make sure that in your light box, we're still getting that medial border of the scapula. So we'll palpate for that as well in that 10 by 12 box. And again, you'll set that 10 by 12 box and you won't touch it. Sometimes we can collimate a little tighter to patient anatomy. So notice that there's a nice big space between the bony thorax, all the ribs, and the scapula itself. They shouldn't be touching if the patient is rotated enough. So down here we can also see shoulders that are anteriorly dislocated, posteriorly dislocated. So we should see nice superimposition. If we don't see that, then that's a good sign. Either the patient was positioned poorly or they have that dislocation, which is why it's really important to try to position properly for this image in particular. And remember, for supraspinatus outlet or Neer's view, it's a modified scapular Y, so position the patient exactly the same. But this time we're doing a 10 to 15 degree caudad tube tilt. So instead of pointing upwards, we're pointing down toward the floor. And it gives us a really nice view of the supraspinatus outlet, where the supraspinatus muscle would be sitting. So if we were looking at the posterior scapula, this is where that supraspinous fossa would be. This is the spine of the scapula. And we're seeing it kind of in profile as it comes around to form the acromion. So that rotator cuff muscle would be sitting here. And it's really the most common rotator cuff muscle that's injured. So oftentimes if they can't figure out why it's being injured, they'll look for any like bony deformities through either the clavicle or the acromion to see if there's anything that's actually pinching that supraspinatus muscle, causing kind of friction injuries over time. Okay, and then you can look at the review questions. They're pretty straightforward. They look pretty similar to what we talked about today. For scapular Y views, for the thickened lateral end of the scapular spine, etc. If you have any questions on what the correct answers for those are, please let me know. I can let you know, and I can post a key if necessary.